Understanding the role of surgical resection margins in pancreatic cancer treatment. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has heard terms like R0 or R1 resection during pancreatic cancer discussions, you're in the right place. I know when you hear medical terminology during an already overwhelming diagnosis, it can feel like doctors are speaking another language. Today we're going to demystify these terms completely. By the end, you'll understand what surgical margins mean, why they matter for your outcome, and what questions to ask your surgeon about achieving clear margins. Before we dive into R0 and R1 classifications, let's establish what we're dealing with. A surgical margin is the edge of tissue removed around a tumor. When surgeons remove cancer, they're not just cutting out visible tumor, they're removing a rim of normal tissue around it to ensure no cancer cells remain. This concept is illustrated in these two images. The pathologist then examines these edges microscopically to determine margin status. This matters personally, because margin status powerfully predicts whether cancer will recur and your survival after surgery. The R classification communicates what was achieved during cancer surgery. An R0 resection means microscopically negative margins. When pathologists examine tissue edges under microscope, they see no cancer cells at the margin. This is the gold standard. Safe achievement of an R0 margin is the main surgical objective for extended survival. An R1 resection means grossly negative but microscopically positive margins. To the naked eye during surgery, the surgeon appeared to remove all cancer, but under microscope, cancer cells appear right at the tissue edge. An R2 resection means grossly positive margin. Tumor was visibly left behind during operation. Here's where it gets interesting. Research shows positive margin rates range between 15 and 85% across centers, and when present, these regularly predict decreased survival. However, multimodality therapy, combining surgery with chemotherapy, may improve R1 survival to approach R0 outcomes. The survival curve here is illustrative of this concept. Now you might be wondering, how do pathologists decide what counts as positive? Here's something surprising. Definitions differ between America and Europe. In the United States, the Union for International Cancer Control defines positive margins when tumor cells touch specimen edges, tumor clearance of 0 mm. In Europe, the British Royal of Pathologists defines positive margins if tumor cells are within 1 mm from the margin. This means a specimen called R0 in America might be R1 in Europe. The margin status is reported at 7 locations on surgical specimens. A is seen in this image. Anterior posterior bile duct, pancreatic neck, uncinate, superior mesenteric artery, and portal vein groove. During surgery, surgeons obtain frozen sections, rapid analysis while you're in the operating room, of pancreatic transection margins. If positive, they extend resection immediately. They do the same for biliary margins, which are rarely positive. But here's something critical. Retroperitoneal and superior mesenteric artery margins aren't sent for frozen section because there's no ability to extend them. Unfortunately, even apparently resectable tumors may have positive posterior margins that can't be assessed until after resection completion. The major goal of surgery for pancreatic cancer is R0 resection. Margin-positive resection strongly predicts early recurrence and short survival. But let me give you context with actual data. In borderline resectable tumors where patients receive neoadjuvant therapy, that is, before curative surgery, R0 resection rate was 63%, median survival was 23.2 months, and 5-year survival was 18.4%. In this image, you can see how the tumor encroaches on major blood vessels, and this is where chemotherapy before surgery may be most effective. For potentially resectable tumors with similar treatment, R0 rate was 79%, median survival was 31.2 months, and 5-year survival was 33.7%. In the PREOPANC trial comparing upfront surgery to preoperative therapy, R0 rate was significantly higher with preoperative therapy, 71 versus 40%. 5-year survival with neoadjuvant therapy was 20.5% versus 6.5% without it. I know these numbers can feel overwhelming. But here's the important message. Long-term survival is possible, even with positive margins. In the Charité Oncology trial, 15% survived 5 years despite high-risk features. Patients with positive margins saw greatest survival increases as more time elapsed since treatment. The term borderline resectable describes patients with limited vascular involvement at high risk for margin-positive resection. These patients are good candidates for neoadjuvant therapy. That implies giving effective chemotherapy before surgery to downstage tumors and improve complete resection chances. Research demonstrates that patients with borderline disease receiving intensive FOLFIRINOX chemotherapy followed by radiation achieved R0 resection in 65%, with median survival of 37.7 months. Among those undergoing resection, 2-year survival was 72%. Neoadjuvant treatment increases margin-negative resection rates and helps select patients, if tumors progress during preoperative therapy surgery, might not offer survival benefit. In this CT scan, you can see how the size of the tumor has reduced with chemotherapy. About your surgical center. Ask how many pancreatic operations your surgeon performs annually. High-volume centers doing more than 15 to 20 resections yearly have better outcomes with R0 rates reaching 84 to 97%. About margin definitions. Ask which R0 definition they use, American 0 mm or European 1 mm. This affects pathology report interpretation. About neoadjuvant therapy. If you have borderline or high-risk potentially resectable disease, ask whether neoadjuvant therapy might improve R0 chances. PREOPANC showed this improved R0 rates from 40 to 71%. Sample questions. What is the R0 resection rate at this center? Do you check frozen sections of margins during surgery? If margins are positive, what additional treatments are available? Seek high-volume center evaluation if your tumor is borderline resectable, scans show tumor vessel contact, you've been told surgery isn't possible, or pathology showed R1 or R2 margins. Look for margin status at all 7 locations, distance in millimeters from tumor to each margin, and which specific margin was positive if R1. Ask about tumor grade and lymph node involvement working together with margin status. These 2 images demonstrate Whipple surgical margins and lymph node status, N0 being no lymph nodes involved. Timeline expectations. With R0 resection and adjuvant therapy, surveillance depends on institutional protocols. This may be limited to surveillance of nutritional status, well-being, and CA19-9, or imaging every 3 to 6 months for 2 years. High-risk features may need closer monitoring. Achieving R0 resection with clear margins remains the strongest predictor of pancreatic cancer survival, though modern multimodal therapy offers hope even with R1 margins. Your next step. Consult an experienced pancreatic surgeon at a high-volume center to discuss margin risk and treatment sequencing. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic, including National Comprehensive Cancer Network Guidelines and American Society of Clinical Oncology Practice Guidelines. All links are available in the description below. Thank you for watching.